let's just do it. And welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley. I'm in San Antonio. Bobby's in Iceland. It's still cold somehow in the middle of the summer there. I saw your wife post a picture. That doesn't matter. That's not what we're getting into today. You've got ducks as pets, apparently. Weird Icelandic stuff. But today, orthopedic testing. We're talking about orthopedic testing in relation to, we're going to probably do a low back case, perhaps a shoulder case. Some pretty high level, strong people. We'll get into that more as we go. But really, we want to dive into what does orthopedic testing tell you? What does it not tell you? Are there better ways to assess? And what information can you get out of these assessments in relation to resolving, the thing that walks through the door, a person's injury, and how that relates back to their injury? Both of our people today are pretty strong people, basically. So if you're a strong person and you also have pain, perhaps in your back or your shoulder, this one's for you. If it's not and you're a doctor, this one's also for you. But no, we were just kind of going back and forth about testing. A lot of people, I'll say this, in my coming up back in my day in school, man, I literally had an orthopedic test over malingering tests to see if patients were faking it. I don't know what your situation was in school, but I feel like I did a lot of orthopedic testing, and besides the specific problem, it just doesn't help me that much. Where let's just start from the beginning, man. What did you learn in school in terms of testing?
Yeah, if these ducks show up during this episode, by the way, we're going to have to do a pause and I got to go feed them.
You love those ducks, bro. I love it.
Yeah, they are amazing. And they're timely. They're very, they're prompt. On the same time. Yeah, exactly.
Scandinavian rules, dude. I mean, you guys I get it. It's cool.
Yeah, I mean, similar to you, I remember maybe my school was lucky enough to give me one semester where it was more of a functional movement, maybe therapeutic exercise rehab course or class that we took for one semester. It was I really liked him. He was a great professor, but I had him for one semester, and we learned a little bit about McGill or some Gray Cook stuff or Yonda. And here's a basic way to work on stability, maybe some planks or bird dogs or Palloff presses and stuff like that. But everything else, orthopedic tests. And, when I take national board exams and pay couple $1,000 to take them, I was only tested on, empty can test and Hawkins Kennedy and Gainsland's and all these tests that we all know. And it does kind of set you up for starting your practice, or at least working with patients, as that is your mode of evaluating the patient. I mean, if you come out of that background, as many chiros do, I think the physios and PTs probably have a little better maybe evaluation process starting out. I would just guess, depending upon most schools, but still, I mean, I still know a lot of physios and PTs that kind of have a similar system of, doing the orthopedics and, okay, I know it's your supraspinatus, and rub that spot and give some banded ER or IR or whatever it is. And that's it. When you maybe put some stim on it or ice or cup it or needle it or anything you can to take that pain away from that shoulder. But I just personally never liked that, because I didn't, some people get better and some don't. And I never knew, I've said this before, I never knew why they were better or why I fixed one person and didn't fix the next one. And that was never very rewarding or satisfying for me.
Yeah, no, that makes sense. I mean, the idea with the basic testing is that, okay, I figured out that the supraspinatus is a problem within this shoulder, and, I cup it, I graston it a little bit, and they'll feel better. The patient people are nice. A lot of my patients are really nice. And if I work on the area that hurts for them, and we do, maybe it's just a general range of motion retest, they reach their arms over, we do a general Apley's scratch, right? And it feels a little bit, there's more freedom of movement or something after I Theragun their supraspinatus, then the patient goes, awesome, cool, great. And I'm like, fantastic and successful. But in my experience, and this has been the most frustrating thing, so I try to set up my visits to combat this, is that those patients come back and they're like, well, felt pretty good for that day. I was able to pick up little Johnny and, reach up in my cabinet for things. But I don't know, I woke up the next day and it was just kind of there. And when patients say some version of that, it feels like someone's twisting a knife in my side. And I'm like, oh, because it happened so much it still happens today. And every time I do that, I hear that, I think, okay, something I did, it wasn't wrong, but it wasn't enough. And so my first instinct to repair that was to go harder, was to cup harder, was to grasp in more, grasp in a little deeper. I'll bruise up a supraspinatus. I'll maybe give it a little bit onto your infraspinatus, perhaps even a levator trigger point, just to go a little bit crazy. And then maybe they would get a little bit longer relief. They would be a little bit sore. Given the amount of time, they'd still be like, it's just not quite right. Do you know what I mean? Does that sound familiar at all, or?
Yeah, I mean, we hear that a lot. I think the one time or the one scenario where that does work better is I just did a bunch of something I've never done before and it hurts. Then that kind of works. The person who never does anything with their hands, but then they buy this huge IKEA like entertainment system and they spend like 4 hours screwing in all the things and they give themselves like bilateral tennis elbow overnight.
Right.
Well, that was
marital
because
problems and elbow problems.
exactly. And it still probably didn't come out right.
No.
But yeah, they gave themselves an issue, and sure, we can talk about, okay, they didn't have the capacity to put together a dresser. That's not good, but that's not honestly fair, because there's many things. You could be a high level runner. It still doesn't mean you can cycle or jump or squat or throw. So we're all going to be deficient somewhere. And if you're just not used to doing that, putting together that dresser can just flare up a bunch of stuff that is not used to that load. In that case, I think the traditional model works, which is put some ice on it, or needle it, or put the hydrocollator on it and just calm that thing down, ice it, rub it, ART, whatever you want to do, and say, hey, okay, don't put any dressers together for the next few weeks, careful with the doors, don't squeeze stuff too hard, and then they get better. And you don't have to figure out their problem. You don't have to evaluate every joint. Just keep it easy and they'll probably be fine.
Sure.
But for everyone else, I think I agree that we get that. That was always troubling for me. Well, yeah, it felt good for a couple of days, and to be honest, I think some clinicians like this model because the patient is very dependent on you, and that's a great business model. It's the dependency model. I don't know, just never did anything for me. If I can sustain my livelihood without the dependency model, I'm going to go that way. So.
Yeah, no, like, okay, so that sometimes, okay, people will get better in that sense. And maybe their lifestyle is such that a couple of visits and I bang the heck out of their lateral elbows, their extensors, give them some of these little stretches, right? And then they're good to go. And that problem is fine. And that gives me enough juice to be like, I'm a good doctor. I got this. I'm a good doctor. However, I do know that there are some of those patients that will come through, and being a good doctor, I'll go back to that same model of treatment and won't have those results. So they'll come back. Now, I want to very quickly, before we go to where I would really like this episode to go to, is jump to the ditch on the other side of the road. Because this is, and just a heads up, if any of this sounds familiar, Bobby and I have both been listening to Dr. Spina's Control Yourself podcast, and it's fantastic, and you should go over there. So if a couple of these concepts sound familiar, he's a big inspiration. But he mentioned a thing, which is, I know, a common solution that some doctors will give. They'll go, you need to move more often and just be more active. You know what you need to do. Just move more, shake it up. Variety is the spice of life. Join a yoga class, do Pilates, just move more. And a lot of times people haven't done things. In fact, I have a good friend, one of my best friends back in high school, had some back pain, started doing yoga. Back pain went away. He was a CrossFitter. He was playing pickup basketball, started doing yoga, back pain gone for a while. And so yoga was there when his back pain went away. Yoga fixes back pain. I'm sure you've heard this before. However, it seems as a doctor who goes from specific orthopedic isolating of the supraspinatus via the O'Brien's, whatever test, Yergson's, and then we go, okay, we've gotten to that specificity, but then the next step is to go just move more. It seems like a bit of a leap, and it seems like there's something that could fill that gap. Does that make sense? Where do you start to fill that gap between super orthopedic test and just start to move more, just get active?
Yeah. I do think there is a push I've seen in the past few years of this idea of just move more, just like move nat kind of stuff. And I'm not speaking for that exact company or them, but this idea of, just walk barefoot in the woods and hang from trees and do some bear crawls and whatever you want, just be as natural as you can all the time is mainly good. I think it's a good thing. Anything that gets people moving more is probably a good thing.
Sure.
If you don't have a good shoulder, but you're trying to hang from trees, well, you might wear out your shoulder, but at least you're moving. I mean, some other things will improve, like your heart health and, some other cardiovascular markers and stuff like that. But yeah, it's a little too simple to just say move more, I think. And Spina in his latest episode, his monologue, he was kind of hinting at that. I think he was saying, well, moving more is great, but it still doesn't home in on the specifics or the individualized issue that each person has, So if you have a poor big toe that just doesn't move well, just by, going for more walks or doing more weightlifting or whatever is not going to directly change that exact joint issue.
Mm-hmm.
So, and that's really our role. I think with the amount that some of us charge for things and the amount of school we went to and the amount of maybe, I don't know, respect that we get from our patients that think we have answers, we need to have a little bit more nuance than say move more. And I think that's where these functional or movement screens or the origin of FMS and these type of people came from, Kelly Starrett's stuff. That's the other side of the ditch, I think, right? I mean, not in the sense of the far side of just move more, but trying to say, okay, let's move more. Greg Cook's famous saying of first move well, then move often is brilliant and concise. And it's a good way to segue into this, I would say, into the more effective method, which would be, okay, first you have to move well. So what does that mean? Before you go move often, which would be just go move more. Sometimes that just yields injuries, actually. There's many cases where you tell that the person decides to go do yoga and they make their back pain worse.
Sure.
It's probably flip of a coin. It's, if you don't have a diagnosis on that thing, 50-50 if they're going to make it worse or better, in my opinion.
So, okay, got it. So now let's just take that Gray Cook, move well, then move often. Okay, what does move well mean? Does that mean have a negative Hawkins-Kennedy and O'Brien slap Apley scratch test? What in your mind? Let's get into this. You mentioned to me you had a patient come in who actually, I believe most people would say probably, if they were to look at her, moves pretty well, based off of the accomplishments in their life. But more specifically, what does move well mean?
Well, I mean, I think the move well part, this, for example, Dr. Spina, who we've just been talking about, has made his entire career, or at least his business model, around that idea. And in his definition, which would be this idea of joints need to work well independently first before they can start to become friends with all the other joints in your body. So you can move, so you can make complex movements possible. Each independent joint has to be robust in itself and really hard to refute. I don't have a problem with it. I try to focus on that myself. But then, I could say the only thing I could say is many people are not going to spend their whole lives dedicated to all their joints and making sure they move well. So at least, and I don't think Spina would say that either, but I think at least we could really get to the interviewing or motivational interviewing process where we really discover what the patient's goals are, who they've always been. If they don't plan to ever do a handstand or overhead work, it's just maybe you got to get their shoulders a little bit better, but they don't need to have the world's greatest shoulder car or rotation and wrist flexibility and strength. So at least we can move well for that person. What does that mean for that person? Are they a cyclist? Are they a gymnast? Do they just want to walk without pain? Are they a hiker, skier, on and on and on? And I think that does matter, because most people don't have the energy reservoirs to just do whatever you say. Even if they trust you, they're out of pain. They're going to have even less of a reservoir to pull from, because nothing hurts. So I'll do something, but I'm going to go back to what I enjoy doing mainly.
Right. For sure. So, so you're saying move well means specific to the patients, hopefully a good history that you're taking and listening, and not because move well for me when I first started was I've got a bag of tricks, and I know a couple things to make, say, a hip or a shoulder work better, and I'm going to find some of these tests to match, and I abhor this, the toolbox that I have. And so I will do tests that I know I can fix, and I'll play that game. And I kind of didn't know that I was doing that at first, to be honest, but I would be like, let's find a way to prove that this shoulder is a nail, because check out this cool hammer I got. And that served me well for a little while. But in terms, let's more specifically in terms of, go ahead. Yeah.
It reminds me of, this dystopian FMS community where even Gray himself after a while was like, the point is not to become great at these tests. Where people were just improving their inline lunge, these kind of things. They weren't actually getting better at their sport, or maybe their hip wasn't improving, but whatever input they did, they got better at those 6 tests, and that's all that matters, right? So and Gray was saying that's not really the point. These numbers are just there for pass or fail, and then you kind of where to start, but it was never about improving the tests. I mean, nobody puts a dowel behind their back in inline lunges anyway. Right. So,
and you have to be careful as a doctor, because when you do those tests, you're conditioning your patient to be like, this is the measure for a healthy shoulder. They don't know, you know what I mean? Especially if you're doing, these couple orthopedic tests with this long lever traction, and they have their significant other test some of these isolated rotator cuff. Man, I'm not good at fixing orthopedic tests specifically. For those are ruling out pathologies for me. They don't necessarily help me get a patient better, back to our initial thing. So that said, when you do pick tests, because there are those patients that are really dedicated to what it is you're doing, you're getting them better. They trust you as the expert. And so if you give them an inline lunge with a dowel rod on a 2x4, they will get better at that. And then if that doesn't also fix, let's see, their IT band pain at mile 4, they're like, but I'm great at inline lunging. You'll see that there's that kind of disconnect. And this is going back to what you were saying about their specific issue and desire and need in life. Okay, so back to these tests. The main thing kind of I got from that Dre episode was to assess the capacity of each joint. And when we move, we have to move in one joint in relation to another. And movement would be a combination of all those joints and the interplay working together. Now, if you were to assess some of those joints, and this would, just to basically kind of run over what his test might look like, you could consider them more of a passive range of motion kind of a test of a humerus on a glenoid, to see how far that humerus could move on that glenoid independently of the whole shoulder complex, right? And so
Actively, I would say he's more active focused. But
fair,
yes.
there are
Yeah.
some passives, but that's the idea. And then once you got that passive marker, you would be able to go through some active tests, the cars, basically
Okay.
moving your shoulder as far as you could. And you would see the little hitches and the giddy ups as you would move your arm around. There would be little spots where it wouldn't move so clear. And that what should look like a circle has little divots in it, little bumps in the road where that capsule is not moving clearly on the joint next to it. And so those muscles and those joints do not have the full capacity. And so you're going to call on other joints to, or muscles nearby to compensate. So for instance, he in that episode talked about shoulder flexion. And you would want to see how far your humerus can move on the glenoid before the entire shoulder complex got stuck together and moved as a whole.
Mm-hmm.
Right. And so he talks about specifically in some of his things, the rotation of a collarbone, stuff like that, which is some old Dio stuff, which I love the specificity of some of his manual work, which is fantastic. But seeing where you could move freely and where you would start to compensate is a very vague way to go about explaining it.
Mm-hmm.
So how do you, like, let's say with a shoulder test, like I'll put a person's back up to the door, at head, back, and shoulders, and then they'll raise their arm up as high as they can go without, letting their low back extend to kind of show them where they're cheating with. And the better the athlete, the better the cheater. I mean, that's just kind of the way it goes. And they'll build in capacity in their extensors, in their spinal complex, without having a real shoulder that moves the way it should move. That's where I kind of start with moving well, would be a little bit more of these joint isolations. And it would still be the standard joint flexion, joint extension, shoulder abduction, stuff like that.
And the reason would be, right, I'm guessing you do that because your orthopedic tests tell you at best what specific tissue is injured, right?
Correct.
If it's specific, if it actually gets everything it's supposed to do, it'll tell you what's injured, but it doesn't tell you why it's injured or how it became injured, right?
Right.
So, that's the problem with the orthopedic testing, is you base it on this idea of we injure something, we do these tests to figure out what was injured, and then we work on that thing. We rub that thing, we needle the thing, like we've already talked about.
Mm-hmm.
So I think if anybody's listening and they're kind of going, okay, yeah, in my first patient visit, I'm doing a lot of pretty much just orthopedic tests. That's pretty much what I do. Then you might want to, it doesn't mean there's nothing wrong with them, and we can explain why they're valid and still useful, but you might want to think about a few tests for different parts of the body that you can start to do to maybe tell yourself more information. Things that would connect the shoulder to the spine, or the hip to the spine, foot to the knee, foot to the hip to the foot, these kind of things. So whether it's a squat or single leg squat or cars or any of these different modalities, these other type of testing styles, and they can tell you they can maybe point you in the right direction towards why they're in the problem that they're in. So it might sound simple, but I still think most practitioners are doing more simple testing or orthopedic testing, and they can say, I know what's wrong with you. You have hip impingement, and I'm going to start my process of how I treat those, which is possibly not arbitrary, but a standard model, which means every hip impingement is a hip impingement, and these are the steps I do. Maybe I do mulligan, maybe I do some distraction, maybe I do some joint mobilizations, or whatever it is, but it doesn't, every hip impingement is not the same. Yeah.
For sure, for sure. It's not. But so like the idea would then be,
You cut out big time. You were gone
yeah,
for a good 25 seconds. Even when I
sweet.
was talking, you were frozen.
Yeah.
Okay, you're yellow now. You were blazing red. Now you're white, so you're good.
Okay. And cue it. So what you're saying is basically the standard treatment model, do a test, fix the area that hurts. I would say the next step would be treatment model of fix the area it hurts and perhaps the agonist antagonist. So pain in the back of the shoulder, I work on the supraspinatus, I work on the infraspinatus. Maybe also I give a pec stretch. I think about a pec minor. I think about this push pull. Perhaps even a next step would be that's on the top of the shoulder blade. We got the supraspinatus, infraspinatus. I understand is below the spinatus, but the spine of the scapula. But then maybe you think lats. Okay, got it. Now I'm looking at lats. At what point do you have to kind of see that perhaps how do I get to I need to inhibit the opposite side lats? Where do I get to? There's a really good doctor at the company I work for, and he can see the matrix clearly. Like it's all ones and zeros all over. And he'll have a right shoulder and he'll go boom, boom, boom. And then he'll say, okay, your right shoulder hurts. Let me also work on your left hip flexor. How's that right shoulder? It's amazing now. And he has, and I've talked to him, he will build a narrative in his mind via a good history, via movement testing. I think he's got an incredible eye to see these things. And he'll connect how that left hip flexor relates to that right shoulder extension. And it's mystical the first time you see it. And if you ask him to explain it, he will. But in from treating just localized pain stuff to jumping to stuff like that, you're like, how in the heck do we get there? And I think part of it, what we were saying, are those larger movement screens, like when we say an inline lunge and an overhead thing. You can start to piece some of these things together. A lot of people talk about like a butt wink. And I'm not quite sure what that means, to be perfectly honest, on a squat. It means a weight kind of shifts to a side. But how, if I'm a new doctor, how do I go from isolated, localized treatment to perhaps getting a little bit more of those global things and seeing maybe, you know, on a single leg squat or an overhead squat test where I can be like, I need to treat your supraspinatus, but I also need to treat your left pec. And I can give some good reasoning. Like, where's the gap to that? If that makes any sense as a question.
Yeah, and that's experience and a lot of reflective, critical thinking, and I do think you're going to fool yourself a lot along the way, and I think even the best of the best can be confident on things and still miss it. I just think it's too complicated for everybody to understand everything. But you talking about your friend does a lot of testing and stuff. Well, that's good to hear, because sometimes I've heard like, well, he just looked at me and he said, I know it's wrong, lay on the table. I can tell that your right, QL's not matching up with your abductor hallucis. And it's like, you don't know anything about that person if they don't move.
Right.
You can have flat feet that have amazing strength and mobility and coordination, and you can have a perfect arch where the person can't. There's toes just shake when you try to do, a flag waving type of exercise. So you don't know anything until they move, until you ask them to do things. You take as many courses as you can, and you try not to become cultish in any one of them. You try not to, none of them are the paragon of physical therapy or of chiropractic. So you just take from them what you can, and you move on eventually when you feel like you've got something from it. And you just keep doing this process forever. And this is why some people will never get there, because they're just not going to put that time in. And that's fine. And I don't think I will ever maybe reach the quote guru status of some, because I still like to read novels. I still like to play guitar. I
Mhm.
like to feed ducks. I'm not just sitting in a library reading Sherrington
For
from the
sure.
early 1900s every night.
Right.
And but depending upon what level you want to be or where your passion level lies, will get you there. This is, after that, it's just, in my opinion, it's just
Right.
time and questioning things and trying never to stay stuck in ruts, always questioning what you're doing. And along the way, you may have you have this confidence that isn't right. You say, I think the hip flexor is influencing your right shoulder, and maybe it works out, maybe it doesn't.
Right.
You think you see, sometimes we think we see things and we don't. But as you do this more and more and more, those patterns become more and more obvious. I remember when I was in school, and they're like, do you feel this prominence, whether it's a tuberosity or something? And I'm like, I don't feel anything. This just this guy has to be lying.
Right.
And but over time, you can just start. No, nobody can tell me. There's no scientific article that shows that palpation you can tell when something is too stuck, or there's a. I definitely don't believe we can feel adhesions and things like that. But you can just start to, after a few years, you say, it hurts right here, doesn't it? And they're like, yes, it hurts right there. Well, you can't feel their pain, but after feeling people for several years, you can just start to tell unhealthy tissue versus healthy tissue, in
Right.
joints that have a little bit of soft end feel and joints that don't have it. So when you do the hip scour test, you don't really have to ask them. You're just doing it so you're on the same page. You can
Right.
say, yeah, it pinches right here, doesn't it? And they go, yes. And the early clinician is like, how the hell does that doctor do that? I have to ask the patient every time. Well, just give it a couple of years and a few thousand scour tests, and you will know before you ask the patient if it pinches, does it hurt?
For sure.
So that's the only thing I can say on that topic. Um, but I do, if we can go into either the guy that you have with the shoulder problem,
Let's do yours,
um,
or
or
whichever.
the
Whichever.
sure, we can use an example where I
Yeah.
actually probably did a 50-50 we say distribution of orthopedic to movement tests with
Okay.
her. So this is a games level CrossFit athlete, so somebody that went to the CrossFit games. So they're fit, they train a lot, they've been doing this a long time, they're strong, etc., etc. So
Right.
back pain, I still did orthopedic, especially for low back pain. I do orthopedic testing because I want to know if it's disc, how bad is that disc, and in what movements are we going to trigger that disc. So I want to know if there's nerve root involvement, if there's radiation, where is it at. So if I know which nerve, I can say, okay, let me check the strength of that nerve distribution. This is a good time to do some orthopedic tests. I mean, are they on the verge to really rupturing this thing? I mean, they're just a sneeze away from cauda-equina syndrome. Well, I want to know that, and or
Right.
any red or yellow, red flags. Uh, it hurts really bad at night, and none of the movement matters. Back's extreme pain. I had a guy not too long ago with kidney stones that, after like 2 visits, I'm like, I don't really think this is something for me because none of your tests make sense. And then
Right.
he messaged me a few days later, and he's like, well, I had that lithotropic or whatever vibration, and the stones are gone, and my back pain's gone. So.
Nice.
Um, so with her, she had back pain, specifically on one side, left side, and it seemed discogenic. So I do my tests, but unlike some discs, which are only painful in flexion, she's painful in extension and flexion. And
Mm.
her neutral position is more extended. So she stands extended. She's, if anybody knows PRI, apical expansion is just completely limited on both sides. So she can't keep her ribs down. Basically, she can't keep her ribs down and breathe in. The ribs have to go up. So very extended. So basically in a state of compression on the posterior elements and disc a lot, and a little bit of a butt wink at the bottom so that pelvis reverses at the bottom of the squat. All her pain is in deep movement. So at the bottom of the squat, the pull off the floor in a deadlift, um, cleans are worse because you hold more weight and it'll drive her deeper, versus maybe a snatch is not as heavy and she doesn't have to go so deep, so the back pain's not so bad.
Mm.
So in other words, now I'm trying to look at what I tell her is, why the left side? Like, why is your left side breaking and not your right? Because it can just be, well, that one just happened to break first, but I noticed a little bit of more hip restriction on that side. I noticed that the rib flaring or the rib extension on the left side was worse than on the right side. In other words, her ribs could go down a little bit better on the right than the left. It seemed based on a few tests that the left hip was also a little bit more forward than the right ilium. So in other words, she's just more in a state of extension on the left side than she is on the right side. And we can just call it lumbar.
And like a Thomas test.
Yeah.
Got it.
Exactly. Yeah. Stuff like that. And so if you can just think like the lumbar complex is extended, but it's a little bit more extended on the left than the right. So in my mind, and this is where we create a mental or a vision of what the problem is. And I could be completely wrong, by the way. But in my mind, she's kind of hyper compressed more on the left than the right. And then when she runs into that hip early, she has a stronger reversal of her pelvis into more of a butt wink at the bottom. So she goes from squeezing the donut on one side to at the bottom of the squat, squeezing the donut on the other side. And this is that idea of moving through extension to neutrality to flexion and back under load. If you're just going to squat in Hong Kong and read a newspaper, you're fine. You can go through extension and flexion. But this is not a normal person. This is somebody who lifts heavy weights at high volumes and a lot of training. So this extension flexion cycle is almost like the research that's done in the lab, like on these porcine or these pig models where they take spines and just put them in a machine and just bend them until the disc blows out. That's where a lot of this research comes from. And that's kind of what she's doing, going from extension to flexion under load. And so this was a good example where I could tell where the pain's coming from based on orthopedic testing, but the solution is based entirely on all the other tests. You can see it in the squat, right? You can ask questions of when does it hurt? By knowing it hurts at the bottom of a squat, by the pull off the floor, I'm getting a picture of where the pain is coming from and why, right? So I know now the pain trigger, and I'm knowing, I know the pain location, I know the pain triggers, and I'm starting to see some dysfunctions side to side to maybe figure out why it's left versus right. So it's this holistic approach that helped me kind of narrow down. Now the outcome will verify it or not. And if it turns out she's doing everything I'm saying, but it's not really improving, well, then we got to see, are the tests that I use to base that off of improving, if they're improving and she's still in pain, well, now I'm like, okay, maybe I'm wrong. If they're not improving, she's still in pain, well, then maybe the solution I gave is not effective yet. So either have to keep doing it or we have to change it until we get those tests to change. So once that the hip moves well and she can breathe in while she keeps her ribs down and a few other tests, those become either they change for the better, and then she should be doing better, right? If my theory is correct. So that was a long-winded way of taking you through the whole thing from front to end, but I didn't want to go too deep. So
no, I think that was awesome, man. I loved hearing that, actually. So like, I want to just kind of cap this off probably with like a few strategies, just kind of take home kind of stuff and things that popped into my mind. Like I'm very much like you, outcome oriented, kind of the patient centered, outcome oriented. I don't really have a technique I'm pushing. I want you to get better, and this is specifically about you. So like, I'm thinking, her left to right stuff, you're trying to correct some left pelvic dysfunction in an overly flexed position where it is not able to support a spine perhaps as it goes to that flexion and extension phase through her lifts. But because that pelvis, and this is just my translation, because specifically that left hemipelvis does not support the spine through the flexion and extension phase, what would be, the pelvis should be flexing and extending through a squat, through a clean, those things you enumerated. And because that left pelvis is not, she is getting an excess of load into her low back. And I agree also as well, we were talking about the ribs kind of above not being able to breathe in into that flex state. In other words, there should be a good amount of flexion and extension held through the ribs. Those ribs being up are telling me when you're going through flexion extension, let's just keep it simple. If those ribs are up, more specifically on the left, that left side is in extension. The neutral level between the phase of flexion to extension, she's living in extension always, which is a great place to be in one part of a lift. It's a vital part of stuff. But if you're living on that end, you're never getting out of it and you're just jamming into it further. So rather than being able to flex and absorb some load and tension through the left rib cage, torso, you could say the intra-abdominal area holding pressure, that pressure is then absorbed furthermore into her spine, into that kind of segment that you're kind of talking about with pain. So the first two strategies is, in my mind, and I'm being very general, try to get her left rib cage, try to get her rib cage in general. I mentioned her right side too. Get her rib cage to absorb stress. Teach it to do that. Same thing with that left pelvis, because those are the two, some people say energy leakage, right? They are not pulling their weight. And so that force is being jammed into her back at a high rep, at a high load, repetitively. So this goes back to what I was saying in the last episode. I'm going above and below very quickly to help support that low back. I'll be interested to see how that turns out. But in terms of strategies to fix it, that's what I'm thinking first and foremost.
Yeah. I mean, very similar. I would say still have to worry about the other side because they're both,
of course.
She's extended in general. It's just maybe worse on the left side. So that's could be the reason why it's happening on that side. But my initial focus is to get her neutrality to be not in a state of hyperextension. So get her, her pendulum is not sitting in the middle at rest. It's swung to one side, like you were kind of hinting at. So that way, if we can get her more towards neutrality, well, then you can move into extension from neutral and you can move into flexion from neutral. You're not swinging, you're not always in extension, then you have to swing to flexion. And the real kicker is that you'll see the more extended the individual, the more they reverse completely into flexion at the bottom of the squat. And that's it seems counterintuitive because you're saying you get injured because of flexion at the bottom of the squat because you're so extended. But when you're extended, when the ribs are up in the front and the pelvis is forward, you now close down on your hip range of motion. So in a state of extension, your acetabulum covers the femur head more. So as you squat down, that femur, the neck of the femur, hits the acetabulum early because you're in a state of extension. And so therefore, that femur is now going to drive that pelvis, which was flexed, all the way around backwards into counter nutation, into a butt wink. So you've just smashed the disc and you have it under extension pressure, and then you roll it all the way around into flexion under load. And that can be a recipe for disaster. And I know there's like Greg Lehman, and some people say, well, you can do whatever and nothing really matters. I don't think he would say it's that simple, but that is a time, and I think Greg would probably agree, there's a time when that kind of volume of load on a sheer type of force, like a compressed disc that's going under constant change of extension to flexion and back, eventually wears away on the annulus or on the disc itself. So we need her to be able to start more from neutrality, because if she begins the squat more neutral, she has more hip range of motion, even without improving the hip. She automatically has greater clearance. So you'll see the butt wink go down as the neutrality from the beginning of the squat is there. And then after that, you can work on things like ankle mobility, make sure the knees are fine, and hip mobility. And then you even increase the likelihood of the further you can descend without the hip joint or the ankle joint coming to end range and then driving the pelvis back, right? So at first it's getting her into neutral, and then it's say, okay, let's get that left hip working better,
Right.
and let's check your ankles to make sure they're not limiting it as well. And again, not orthopedic tests, not going to get you there. They're not going to get you to where I just spoke about. So it's that combination that'll, yeah.
No, no, it makes, I'm seeing it pretty clearly. I think what I'm hearing is that you have built a pretty big narrative around her complex kind of movement. And I think that Lehman would argue that you can't prove that, that's his voice. You can't prove these mechanics second to second. And I don't think you're saying, look, I'm doing an x-ray every 2 seconds, but you have created a narrative, a good idea about which direction to go in, essentially. And now you have some things, and I'm gone. I'm back. Where am I? Fuck.
You just got to start over with your,
Okay.
I think it cut out right at where you were going to say, I think Greg Lehman.
I could do it better.
Okay. You're yellow now. Hold on.
We're going to finish. We're going to wrap this up real soon.
Good.
Cool. So I think what I hear you saying is that basically, in relation to Greg Lehman, the Greg Lehman comment, he opposes that you can specify the mechanical problems related to an injury, and you can confirm that and the relation to that. However, I just hear you building a narrative. You're not saying I'm taking x-rays of her in each specific angle and you're determining that those angles are inappropriate. It's just a good story and an idea that you have in your head that gives you an approach with it, essentially. That's what I hear. And Lehman's not wrong, and I understand his biomechanical mechanism, but they're different stories, what you're doing versus what he's kind of saying. And so I think the idea that you want to start her more neutral, give her a bigger buffer zone, essentially, let her use the muscles and capacity that she has. But from an orthopedic, or let's just say structural standpoint, get her body to a more zero level so that she can flex, extend, and twist in all those areas before she starts impinging and shearing on capsules and tissue and beating it up. For me, the last thing I would say is, besides getting a good narrative around their mechanical, painful, provocative movement, would be back to Gray Cook. Honestly, I think people overlook this quote, but he says, the most common reason for an injury is a previous injury. And that said, we can work on the back and we can loosen up a QL or something like that. And the second thing we do is go, what's the next injury? Oh, you had a right knee, perhaps. That was a bummer. And so if I'm not getting progress on that low back via a thorough novel that you built around her back pain story, I'm immediately going to the next oldest problem. That's my secondary strategy. But honestly, it sounds like you've got a good picture of what's going on with her. If you were my doctor, I'd be excited, because I feel like you know what you're talking about, man.
Well, some of it's experience, and then some of it I just get wrong. And then you start to ask yourself, why didn't this work out? And what am I missing? And sometimes it sucks because people fall off and you don't get the answers to the question. And then you just have to move on with another case and think about it again. But I would think if you're on that road and you're saying, okay, I don't think like that yet, how do I get there? I still, we already talked about that earlier, but I still think there's a good role for the people that say, okay, I can do my orthopedic tests. I can find out what's hurting. After that, I'm just going to find dysfunction. Just get good at that. Just get good at seeing it actively and passively, so you can feel things. So, if you don't really, you can always do the passive care. So if something's hurting, you can always rub it and massage it and adjust it or mobilize it or whatever you need to do to help it. But then after that, like if you're just like, I don't know how to put that narrative together. Well, honestly, you may be better than the people creating a false narrative if you just say, if you think a little bit more like Spina and say, what works, what doesn't work well, and how do I make that stuff work better? So this ankle sucks. This hip also sucks. She can't rotate. I'm going to give her the things to work on those things. That's all. But that's what I can see. And I think that will go a long way. And then you can obviously apply the pain care, to take their pain down, or if they're dealing with pain, that's fine. But you'll go a lot further than arbitrarily throwing, just 12 exercises off of whatever rehab program your office has installed on the computer at them. The same ones, most likely. Do this
For
monster
sure.
walk, do this bridge, and that should take care of your back pain.
Bro,
So,
light bulb, and then we're gonna wrap this up.
yeah.
I've thought this about the way that you've talked about your rehab before, and I've never said it to you, man. But I do think there is a perspective, and there's nothing different that changes about the process except for the perspective. The entire world is the exact same. You just see it a little bit different. I think, let's just go back to like an architect. I feel like you have an end game. You want things to look a certain way. You have an end model in your mind about how those ribs, how the spine, how the hips should all move in concert. And then you have a bridge that you are building to get there. So I'm building a deck in my backyard. At some point, there's just some holes and some dirt in my backyard. And I've got a couple posts. And the patient goes, man, my back's not better yet. And you go, hold on, we got to lay down some other stuff. I feel like the way that you describe your patient's pain, your process of injury, your ultimate goal, you have an end game. You have your dream house built in your mind. And now you're trying to figure out ways to actively get to that. And on the process of getting there, you're like, oof, we found out the ground is unlevel here. We may have to make a little bit of an adjustment. And I think that's one of the big things in terms of your treatment that I've actually stolen quite a bit. Having a pretty clear process of where I want to get this person to. And then along the way, the steps might change a little bit, but I've got a pretty good idea.
I'll take that. And sometimes, to be fair, creating the narrative can be easier than laying down those planks of wood. You know what I mean? Because you can know where you want to get them, and that it sounds easy on paper, but that can be very difficult to get a hip to start to truly change, or to tissue to truly start to adapt to certain loads. It takes work, and it takes, that's where you have to get the patient to believe in you and maybe commit to longer term care sometimes, or trust your advice, or do your active care.
Right.
Man, building the deck can be harder than the vision of the deck. So that's a totally different skill. So I feel like I struggle more with that.
I think it's better than just being like, let's build a deck, let's go for it. And you do need to do that sometimes before, we're going to figure some things out along the way. But I do think that if a lot of people could have a better picture of the end game in mind, that the process of getting there would seem a little bit more clear than before. That's what I would recommend. Really just listen to Bobby. Every once in a while, something comes up on my end, but really pay attention to what he says. Check out Dr. Spina's podcast. Definitely do that over Bobby for sure. And check out Gray Cook, but more so check out like our Instagram and like our YouTubes, and have a great week. Peace.
See you guys later.